Hi guys, Lizzie Barrett, the nurse educator from intensive care here. Just a quick talk today, a survival guide to CPAP. So if you're after a really detailed overview of non-invasive ventilation, I have recorded another lecture on that gives you the basics. It goes for quite a while. It's about 50 minutes, but it covers both CPAP and BiPAP. In detail. This is really like a 5 to 10 minute quick survival guide. So not designed for those who've never done CPAP before. This is a quick refresher, quick reminder of the things we need to know to apply this therapy in the clinical setting. Again, generic in nature, so please refer to your local policies, procedures and guidelines wherever you may be, because there are differences from facility to facility and there are differences from machine to machine. And this is very much about non-invasive ventilation or CPAP delivered in the acute setting. So we're not talking about CPAP for chronic conditions in chronic patients. All right, so NIV, non-invasive ventilation, we are applying a positive end expiratory pressure via a face mask, whether that's an oronasal mask there on the left, a full face mask there on the right, but never ever in an acute setting do we do this via a nasal mask. And we don't do it via a nasal mask because we cannot deliver a positive end expiratory pressure we can't guarantee the delivery of a set positive end expiratory pressure because a lot of the gas flow and therefore the pressure can leak out of the patient's mouth. So not used in the acute setting in an acute respiratory failure condition. CPAP, continuous positive airway pressure, can be delivered via a variety of machines, and different places have access to different machinery. And you may be using a machine that you're very familiar with, or you may be using a machine that you're very new to, and hopefully you've had some ward-based training on that. But CPAP is the delivery of end expiratory pressure. So we are applying a pressure that the patient feels, and where we see the clinical effect is at the end of expiration, so as they're breathing out. Machines can be quite complex in their look and feel, and they can be quite simple in their look and feel, but fundamentally they're all doing the same thing while they're applying this therapy. Oxygen is the other thing that we need to set when we're delivering CPAP. So we're going to set an end expiratory pressure, but we're also going to deliver an oxygen. And oxygen can be expressed as a fraction or a percentage. And I've put the conversions or some examples of the conversion down there in the bottom left. So if we're expressing our oxygen as a fraction, 100% would be expressed as 1. So 1 is a whole. So an FiO2 of 1 means that we're delivering 100% oxygen. An FiO2 of 0.3 means that we're delivering 30% oxygen. On some machines, you will have an oxygen tubing that goes up to a wall flow meter. That might be high flow or low flow wall oxygen, and you're going to deliver oxygen in litres per minute by dialing it up on that flow meter. On your machine itself, it may convert that into a percentage of oxygen that's being delivered to the patient. So you might put on 6 litres and then on the machine it says that you're delivering 35% oxygen. But in some cases it won't do that. So you'll just have the flow meter set and you'll change that litres per minute up or down according to an end result. And by that I mean saturation. So you'll titrate that according to whatever your order is. So it might be 90%, 88% or 92%. You'll move the oxygen up or down. So PEEP. PEEP is the pressure that we apply at end of expiration. And in fact, it's actually a continuous pressure that's applied throughout the entire respiratory cycle, but where the patient feels it is at the end of expiration. So here we have a time pressure waveform. So we've got time across the bottom, pressure up the side, and airway pressures are measured in centimetres of water. And you can see the PEEP is labelled here, and we've set it at 5 centimetres of water. So when the patient exhales, the pressure in the airway and lungs does not drop below 5 centimetres of water, because that is what we have set. And why is that important? That is important because PEEP helps us keep the alveoli, or the little air sacs in our lungs, open for longer throughout the respiratory cycle, which helps them participate in gas exchange for longer. PEEP has a direct relationship with oxygenation. So PEEP splints the alveoli open. So as we breathe in, normally alveoli open like a balloon, and then as we breathe out, they close down. And as we breathe in, they open, and as we breathe out, they close down. When we apply PEEP, or a positive end expiratory pressure, We breathe in and the alveoli open, and as we breathe out, because there's a positive pressure, the alveoli don't close all the way down, they actually remain splintered open. So useful for continuing to exchange oxygen and useful for pushing fluid back into the circulatory system. Just a note, PEEP is used interchangeably with the phrase EPAP, which is also used interchangeably with the word CPAP. So they all mean the same thing. They are a positive pressure applied at the end of expiration. So what do we need to apply this therapy? Well, we need our equipment. We need to get a machine, we need a circuit, we need some way of humidifying the circuit, and hopefully you've watched the talk by Anwar on humidification, whether that's active or passive, so a water bath or a HME. You need an appropriate size mask, otherwise known as an interface, and any protective dressings you're going to apply to the patient's face. You need to confirm your order, and for CPAP, you need two things ordered. You need a starting oxygen, and in most facilities, nurses are allowed to titrate oxygen, but again, please adhere to your local guidelines around whether you can do that. And we need a CPAP or a positive end expiratory pressure or an expiratory positive airway pressure, PEEP or EPAP, whatever you're used to using, documented. Now, we would normally start at say 5 or 8 and work up from there, and you would never normally go below 5 centimeters of water. So 5, it would be a minimum PEEP setting. In a ward-based environment, anywhere up to about 10 or 12 would be considered okay. And again, this is quite generic. Different places are going to be happy with different levels in different environments. But more than 10 or 12 of PEEP would be considered quite a high level of PEEP. So we need to be thinking to ourselves or having a discussion about, is the patient on the right ventilation settings? Do we need to put them on BiPAP, or do they need to be referred to be looked after in a different area, whether that's a specific respiratory unit or an intensive care unit, because PEEP itself can have effects on the hemodynamics, and it's important that we're aware of that. Once you've got your equipment and you've got your order, you need to obviously set your machine up, program your machine, and you need to explain the therapy of the patient to the patient, and you need to provide reassurance and stay at the bedside while you're initiating that therapy. It's very uncomfortable. It can feel very claustrophobic, and patients need your support to ensure that we can successfully initiate CPAP. So when you start the therapy, you want to apply the mask to the patient's face. My personal practice, and that's not set in stone, it's not right or wrong, but my personal practice is to just hold the mask firmly with my hand until the patient gets used to what it feels like. I find that it actually increases the success rate of them, I guess, being okay with the therapy. It feels very uncomfortable, and again, it can be very claustrophobic. We're putting this hard plastic mask over their face, and with you just holding the mask there, it gives them the reassurance that they can actually just very quickly remove it or pull it away if it gets overwhelming or too much. Whereas if you've already strapped it on with the head straps, it's very tight, it's all confining. Patients can panic, they don't like the feel of it, they just want it off. So I just hold it with my hand until the patient is settled, and for some patients that's 5 or 10 breaths, for some patients that's 5 or 10 minutes. And then after that, I apply the head strap, fasten and assess for leaks. A warning about circuits, 2-limb versus a 1-limb circuit. So a 2-limb circuit, which is the one here on the left, you have an inspiratory limb and you have an expiratory limb. So gas flow and oxygen gets delivered to the patient, they breathe it in, and as they exhale, the gas flow and the exhaled CO2 is taken away by the expiratory limb and dealt with by the machine. In a 1-limb circuit, you have a single limb where gas flow and oxygen is delivered to the patient. When the patient breathes out and exhales all of their CO2, it needs to escape the mask somewhere. So in a 1-limb circuit, you need to have a vent or a hole either in the mask or in this piece of plastic immediately adjacent to the mask for all of that gas flow and the CO2 to be passively dispersed into the atmosphere. If you don't have that hole or a vent in the mask, what's going to happen is the patient's going to breathe all that gas flow out with the CO2. It's going to stay in the mask. They're going to rebreathe their CO2 in subsequent breaths, and they're rapidly going to become unconscious. So it's a safety thing. Just be mindful of that. So 2-limb circuits are generally completely closed. 1-limb circuit needs to have a vent in it. Some units will put a viral bacterial filter on the exhalation vent, wherever that is. in their COVID patients to try and manage that viral load a little bit in the atmosphere. Again, refer to your local practices as to what you need to do. So assessing response. So good respiratory assessment is imperative. In these patients that we're applying CPAP in, you want to see an effect within the first, I'm going to say hour, 90 minutes or so. If we haven't seen an effect, and they don't need to be completely fixed, but we want to see their work of breathing decrease maybe a little bit. We want to see their oxygenation improve a little bit. But if nothing's changed, we need, again, to be consulting with our medical colleagues and thinking to ourselves, do they need more PEEP? Do we need to change them to BiPAP? Do they need to be referred for invasive ventilatory support or monitoring and observation in somewhere like an intensive care unit? But looking at overall work of breathing, our respiratory rate saturations, any blood gas results that we might have, and always be mindful of our other hemodynamics, because that can be an indicator that a patient is worsening or that the settings that we're having them on are having a bigger hemodynamic effect. So thank you for your time today. I hope this has been helpful for you as a quick refresher and a reminder about CPAP in the clinical setting. Stay safe, stay well. I'll see you next time.